Good afternoon, everyone, and thank you for joining us today. I'm Catherine Tier, Associate Director of Market Analysis and Insight at the California Healthcare Foundation. For those of you who may be new to our work, CHCF is an independent, nonprofit philanthropy focused on improving California's healthcare system, especially for Californians with low incomes and those communities that have historically faced the greatest barriers to care. For 20 years, our regional market reports have been an important piece of our work. They're designed to give healthcare leaders, community organizations, and policymakers the data they need to understand and strengthen the unique healthcare systems across our state. To develop these reports, our authors spoke with more than 200 local healthcare leaders in 2025 to capture on-the-ground perspectives and identify important trends across 7 distinct regions in California. We heard from people leading hospitals, physician groups, community health centers, Medi Cal managed care plans, behavioral health CBOs, and many others. We are extremely grateful for their time and their insights. This is the third of the webinars and in-person convenings that we're hosting to share findings from the regional market reports. I'm especially excited to help present this one on the San Francisco Bay Area, Alameda, Contra Costa, and San Francisco counties specifically, because this is where I live and work. And clearly many others share my interest given all the people who are joining us today. In a moment, I'll turn things over to Caroline Davis, the lead author of this report, to walk us through some of the major findings. After Caroline's presentation, I'll be back to moderate a panel discussion featuring perspectives on policy and operational challenges, new initiatives, and emerging opportunities to improve healthcare across the region. One quick logistical note before we would begin. We will have time for audience Q&A toward the end, so please go ahead and submit your questions in the Zoom Q&A box as we move along. And at the end of the webinar, there will be an online survey that we very much hope that you'll fill out. With that, let me welcome Caroline Davis.
So I'm really glad to be here today and excited to share the findings from the San Francisco Bay Area Regional Market Report. All right, before I jump into the findings from the report, I just wanted to spend a quick minute talking about the project kind of writ large. As Catherine said, this is the 5th round of the regional market reports. So this is the 5th version or update of this report for the Bay Area, which has been one of the regions since the very beginning. You can see on the map on the right-hand side the regions. There are 7 study regions for this round, and they are highlighted here on the map on the right-hand side of the slide. I guess the other thing I will just say is the purpose of these reports is to gain insights into how healthcare is organized, what the delivery system looks like, how healthcare is financed in communities across California, and then, of course, over time. So as Catherine said, we will be producing 7 reports, 1 for each region. They will be released over the course of this year. The Bay Area is the 3rd of the 7 reports, and we are conducting webinars or in some cases in-person events for each of the reports. So be sure to check out the Foundation's website if you want more information about any of that. Next slide. So just a quick note about our approach and how we did the work for these reports, how we are conducting the work for these reports. So they are a combination of both qualitative information as well as a lot of quantitative data that we've gathered from many sources, some from the state of California's various departments, some federal data like the US Census. We also used data sources such as the California Health Interview Survey. We couple that with a look at all of the news stories and industry reports, government meeting proceedings, all sorts of information about what's been going on in each region over the last 4 or 5 years. And then we do a set of interviews to collect the qualitative data. So for the Bay Area, I interviewed 26 regional leaders from across the healthcare spectrum, including hospitals, community health centers, other provider organizations, health plans, county government officials, and other regional experts. And those interviews for the Bay Area report were conducted just about a year ago, between April and July 2025. Next slide. So in terms of kind of the general population characteristics of the San Francisco Bay Area region, in 2023, there were about 3.6 million people who called the Bay Area home. The Bay Area is a mix of urban, suburban, and rural areas. And then as you can see here, compared to California overall, Bay Area residents tend to have higher incomes. They have a lower poverty rate and a lower unemployment rate compared to California overall. Next slide. So then looking at the sources of health insurance in the region, as you can see here, about 2/3 of Bay Area residents have commercial insurance compared to just a little over 50% of Californians overall. In terms of the Medi Cal program, about a little over a quarter of Bay Area residents have Medi Cal coverage. That compares to 35, almost 36% of Californians statewide. And then in terms of the uninsured population, about 4% of Bay Area residents were uninsured compared to 6.4% of Californians overall. And all of this data is from 2023. Next slide. So that's a great segue into talking a little bit about the Medi Cal managed care landscape in the region, which has undergone some changes in the last couple of years. So for many years, all three of the Bay Area counties were part of what's known as the Medi Cal 2-plan model. And that's a model in which enrollees can choose between a publicly run local initiative health plan or a private commercial plan. In 2024, however, Alameda and Contra Costa both decided to switch models and change to what's known as the single plan model, which I think by its name is obvious. That's a model in which there's a single plan for enrollees to enroll in when they are come into the Medi Cal program. That meant, of course, that Anthem, which is the longtime commercial health plan in both of those counties, exited the Alameda and Contra Costa markets for Medi Cal. At the same time that switch was happening, Kaiser also was entering into a direct contract with the State Department of Healthcare Services in a number of counties across the state, including all three Bay Area counties. So what you can see here in the table is that what has been true for many years still remains true, which is in each of the counties, the local health plan holds a majority of enrollment for the Medi Cal enrollees. Next slide. So the Bay Area is home to four large health systems or major health systems. Those are Sutter Health, UCSF Health, Kaiser, and John Muir. So just to give you an idea of scale, Sutter Health and Kaiser accounted for almost 50% of discharges in 2023. As you can see in the table here on the right, the hospital net income margins in the region are much lower than the California average. Negative 2.3% in the Bay Area compared to 4.5% in California as a state, the state level. Even so, all of the large systems have been expanding, and it's been particularly true in the East Bay. They've been expanding outpatient capacity across the region. They've also been building new hospitals to replace existing facilities and meet the state's seismic requirements, which are due to take effect in 2030. That includes UCSF Health, which is replacing its Moffitt Long Hospital in San Francisco. Sutter Health has also announced plans to build a new hospital in the Bay Area, in the East Bay city of Emeryville, and that will replace their Berkeley Hospital. In addition to the construction work that's been going on, there's also been some consolidation. UCSF Health acquired two hospitals from Dignity, both in San Francisco in 2024. Alameda Health System, which is the public health system in Alameda County, affiliated with St. Rose Hospital, also in the East Bay, and that's a hospital that has been struggling financially for many years. As one interview respondent commented, competition among the big systems is more intense now than it ever has been. Next slide. So just as there's been consolidation in the hospital sector or the health system sector, the physician sector has continued, or the provider sector has continued to consolidate. The number of independent practice associations, IPAs, and medical groups has continued to decline. That's due for several reasons, but one that was highlighted in the interviews was that smaller practices and smaller groups tend to lack the scale and the resources needed to participate in risk-based payment arrangements. As one interview participant said, the economics don't work really for private practice as well anymore. That said, there are some bright spots. Hill Physicians, which is the largest physician-owned IPA in the region, has been working to keep private practice viable for its member physicians. They've been launching a number of strategies and initiatives around that. And then just as the prior report was being published, Blue Shield of California Health Plan had decided to borrow an idea from United and their Optum model, and they launched Alteus. And that's a physician organization that supports more than 10,000 physicians, most of whom are in the greater Bay Area, so the 3 Bay Area counties and the kind of surrounding counties. But they've also been expanding into Southern California as well. Next slide. So the Bay Area is fortunate to have a very robust safety net. Each county operates a public hospital or health system, as well as a number of outpatient clinics or FQHCs. As you can see here, in 2023, Medi Cal accounted for a significant share of the discharges for each of the county systems, ranging from 51% for Zuckerberg San Francisco General to as high as 74% for Contra Costa Medical Center. So I'm sure it will come as no surprise that all of the public hospitals and health systems voice their concerns about the impacts of the budget cuts coming at the state and federal levels, and particularly in the Medi Cal program. Next slide. The region also is home to a number of community health centers and FQHCs who play a really critical role in terms of serving the safety net. Those clinics are a mix of county-run and hospital-based and community-based clinics. And the data from 2023 show that the community health centers in the Bay Area have fewer patients and encounters than the statewide average. That said, they also see more patients with incomes below the federal poverty level, and they have a smaller share of net patient revenue that comes from the Medi Cal program. Next slide. So looking at workforce kind of writ large in the region, you can see from the table here that the Bay Area has a fairly robust workforce overall compared to the statewide average. Not to say that the statewide average is the right number, there's probably never enough, but the Bay Area fares pretty well compared to California at the state level. With that, though, specialty care access challenges do persist, and respondents called out in particular neurology as one shortage area, and then behavioral health providers of all types was also highlighted. Respondents also commented on how difficult it can be to recruit and retain providers to the Bay Area, given the Bay Area's higher cost of living than other regions in the state, and certainly than other states. And safety net providers, the work they are doing is highlighted in the report around all of the programs and initiatives they have put in place to recruit and retain providers. That includes residency programs for internal medicine, but also more local efforts, such as one of the safety net providers in the region is partnering with its local community college, for example, to train psychiatric technicians. So they're really trying to grow their own, they would say, to help ensure access for their patients. Next slide. So as many of you probably know, the California Medi Cal program has been undergoing a number of changes in recent years, all under the umbrella of what's known as CalAIM. There's a lot of support among the respondents for the Bay Area around the CalAIM initiatives as a whole. And you can see here, though, that take-up has been somewhat low for two of the really signature CalAIM initiatives, which is enhanced care management and community support services. So for enhanced care management, at the end of 2024, about 1.8% of Medi Cal managed care enrollees in the Bay Area were receiving ECM services, compared to 1.5% overall in the state. And then for community supports, and those are a set of services designed to meet the health-related social needs of the Medi Cal managed care population. So in the Bay Area counties, about 1.4% of managed care enrollees were receiving community supports at the end of 2024, compared to 1.9% statewide. In the Bay Area, the most common or most utilized community supports were medically tailored meals, housing transition and navigation, and then housing tenancy and sustaining services. So implementation has not been without its challenges, in part because many of the providers serving as the ECM and community supports populations or enrollees are community-based organizations who might not have had a lot of experience contracting with a managed care plan prior to CalAIM. And that has been a real challenge, particularly for billing, in terms of billing and reporting requirements that come along with those contracts. Some work has been going on in the region to try to support those local providers, and in particular, hub models were beginning to take hold at the time of the interviews. And that's where a single organization holds the contract with the health plan on behalf of the service providers, and then that single organization handles all of the back office or administrative functions and is really the go-between with the plan. So Kaiser uses this kind of a model for all of its enhanced care management and community support services across its service area, including the Bay Area. And then in Alameda County, the health agency serves as a hub for 21 organizations for the 3 housing-related community support services. Next slide. So another area that was highlighted in the interviews is the priority around addressing behavioral health and homelessness. Similarly to what's been going on with Medi Cal on the physical health side, there are also a number of initiatives within CalAIM, but also at the state more broadly around Medi Cal behavioral health transformation. The counties play a really key role in that work. They are responsible within Medi Cal for the specialty mental health and substance use disorder treatment services. And a number of respondents commented on just the volume of work and the timeline, the time pressure to get those initiatives up and running, and how that has been overwhelming for counties. That said, there are several bright spots I want to highlight. One is San Francisco's Mental Health SF initiative, which is aimed at providing or improving access to behavioral health services for people experiencing both homelessness and serious mental illness or substance use disorder. And then in Alameda County, voters did approve a sales tax increase, and those funds or that revenue is funding housing and services for people experiencing homelessness. And then the state's Behavioral Health Continuum Infrastructure, or BCHIP program, has been providing grant funding to organizations across the state to expand access to behavioral health care through infrastructure projects. So maybe building a new facility or renovating an existing facility with the idea that that will support the local healthcare needs. And the Bay Area counties have been, and their organizations have been recipients of that grant funding over the last few years. Next slide. And then I would be remiss if I didn't just talk a little bit about, what's coming in terms of the state and federal funding and eligibility cuts. So just a reminder that interviews were conducted in late spring and early summer 2025, and that was just as federal HR 1, that's the legislation that includes all of those federal Medicaid eligibility and funding cuts, just as that legislation was moving through Congress and being signed into law. So interviewees didn't have enough detail to have started to adjust course, but they were all very well aware of what was going on and what was likely coming. So in California, the counties are considered the providers of last resort for the low-income uninsured resident. They're a low-income and uninsured residents. So at the time of the interviews, they were just beginning to explore how to restart or expand their medically indigent programs, many of which had been wound down when the ACA launched. So they were looking at how to restart those in anticipation of experiencing an increase in the number of uninsured in their counties. Health plans and providers were also concerned about the ripple effect of those higher rates of uninsured across the entire health system. So for everyone who needs to access care, not just the uninsured, what that would look like. And then the other area I want to just highlight that was flagged as a concern is the impact of the reductions in federal Medicaid financing on the safety net, and particularly the safety net hospitals. Next slide. So I just about finished, but wanted to just highlight a few issues to track, and we do include these in every report. They're kind of our attempt to peer into the future. So one is, will the remaining independent hospitals be able to stay independent, or will they be acquired? And what will be the impact of consolidation that has already occurred on both access and costs? How will the region's remaining IPAs and other physician organizations keep private practice viable? It's already valuable. Will they be able to keep it viable? And will the remaining small medical groups be acquired? How will the public health systems and the community health centers respond to those changes that are coming in federal and state healthcare policy and financing? And how will the large health systems, who also serve a large proportion of Medi Cal and Medicare patients, also absorb federal cuts, particularly given their higher cost structures? And last but not least, how will the counties reformulate their indigent programs to provide access to care for the uninsured population? And with that, I'm going to turn things back over to Catherine for the panel discussion.
Thank you so much, Caroline, for walking us through the findings. There's a lot more detail in the report, which is linked in the chat box if anyone wants to go find the full thing. And I'd like to invite the panelists to join me now on camera while we say goodbye to Carolyn. Wonderful. Thank you all so much for being here. This is a very distinguished group, and we don't have time to go through all of their many credentials. So I will just do a quick introduction before we get started with the conversation. We are delighted to be joined today by James Jackson, CEO of Alameda Health System, David Joyner, CEO of Hill Physicians Medical Group, Dr. Eileen Lowe, the Executive Director of Contra Costa Health Plan, and Andy Martinez-Patterson, CEO of Alameda Health Consortium and the Community Health Center Network. So I'm going to start where Caroline left off with her last big slide about the anticipated funding cuts and coverage rollbacks at the federal and state levels. Obviously, we know these will have profound effects across all of our systems. And so I would love to hear from the panel about the most pressing challenges that you're facing and how you're working to address them. So James, can you start and tell us what this looks like from your vantage point at Alameda Health System?
I would be glad to. Thank you very much, Catherine, and thank you all for this opportunity to just share a little bit about what we see as what we're going to be confronting in the future. And so I would offer that for the Alameda Health System, we believe that the biggest challenge we're facing is a significant projected budget shortfall, made even more challenging by the impacts of H.R. 1, which threatens critical federal funding streams that help us continue to provide care. The gap between our community's needs and the resources available to meet them continues to grow, and that is dire. In response to this challenge, we're being very intentional at the Alameda Health System, as well as disciplined. We're trying to carefully manage our finances, prioritizing the services that we believe matter most, and driving efficiencies across our system. As a safety net healthcare system, we really must be responsible stewards of the limited resources that we have access to, and that often means making difficult decisions. And our objective is to keep our doors open for our patients and for the entire safety net. In addition, we're advocating strongly at the local, state, as well as the federal levels, because protecting funding is not just about our organization. It's about ensuring that the patients who depend on us continue to have the care that we know that they deserve. Thank you.
Thank you very much, James. I'm going to stick with Alameda County and Andy, ask you, what do the challenges look like from where you sit?
Thank you for the question. Thank you for having us. And every single thing that James said is correct for the health centers too. I think that speaks to what the safety net environment is experiencing. The changes in Medi Cal eligibility are impacting us greatly in the Bay Area because we are also a sanctuary county. And so we reaped great rewards of having a bolus of our patient population covered by healthcare. And so now to have that appearing to be stripped away is going to hit us really hard. We anticipate up to 40% reductions, which I think any business that has to reduce by 40% in revenue within a matter of a year, 18 months, 24 months, makes it almost impossible. So what we're trying to do is figure out how to land without breaking and then figure out a way to come out of it. For the health center specifically, while they lose 40% in revenue, they still retain the patients, much as just as Alameda Health Systems. Those patients don't go away, they just don't have coverage anymore. So we have been working actively with the county. Alameda is very fortunate. We had not lost our indigent care program in the years after the ACA expansion. We've been using it to expand and strengthen the safety net. So we're in a really fortunate position there. It cannot withstand or cover the gap. I believe I've heard our health plan say there was about a $600 million anticipated loss just in that patient population that will not be covered. The county doesn't have that resource. So we have to figure out how to get a lot more efficient and productive with what we do have. And there are ample opportunities for efficiency. think the challenge is the speed at which we must do so many things, which is challenging. We have launched recently, we're in the middle of trying to improve our outreach and enrollment. This has always been a space for community health centers in the county where we've worked together, but we've never had to be excellent at doing this. And now we must be excellent with the two having to have redeterminations twice. And we know that the system is intended to try to just catch inaccuracies to have people fall off. So we have to get excellent with technology to help us fill that gap. So we are exploring a pilot with using technology to fill gaps that we know that we just do not have enough human beings nor resources to do. And this is a great opportunity for us because while it's horrible that patients must redetermine every 6 months, it's just painful for them. It does give us an opportunity to engage with them in a different way. And so we want to leverage that opportunity and try to build a more cohesive systems, find the efficiencies. And we have been working much more closely with our partners more than ever before because we have to leverage the limited resources more efficiently. Thank you.
Thanks, Andy. Some really interesting things I think that we may want to loop back around to, particularly around technology and also about partnerships. So appreciate your thoughts there. Irene, I'm going to turn to you next. From the perspective of a managed care plan, and we heard a little bit about the transitions across the counties over the last few years. How do things look as you face these next upheavals?
Well, we're looking at all these challenges as being very, very significant. And, over the last few years, there's been a significant push towards moving people into managed care. There is significant value to managed care. And so we're seeing kind of an about face to that, which is, frankly terrifying. Managed care, we're going to be seeing significant decreases in membership, as Andy mentioned, due to changes in eligibility and enrollment. And we're also patiently awaiting the governor's May revise and CMS's final rule to see how much further our membership and our operational processes may be impacted. I think it's super important for all of us to be having conversations. I think conversation and collaboration is the key to get through these challenges. And, here at Contra Costa Health Plan, we have the unique benefit of being part of an integrated health system, Contra Costa Health. And so we're able to converse very closely with our county partners as well as our community partners to be able to figure out the best path forward. It's going to be very, very challenging in the days, months, and years ahead. And we need to be able to work together. I mean, I think this is where we all need to be resilient, nimble, and we also have to be flexible. And at the end of the day, we also have to be resourceful. Change is happening at a startling pace, and we need to be able to keep pace as best we can.
Thanks for all that, Irene. I appreciate it. David, what would you like to add to this question of challenges?
Yeah, I would say, first of all, thank you for inviting me and thanks for doing this report. It's very well done. I would say, first of all, the biggest single challenge we face at Hill Physicians is the fragility of the independent physician delivery system. It's well documented that individual physician practices, independent physician practices, can deliver lower cost, higher quality, or the same quality without sacrificing quality, and a great patient experience. And for many patients, a much more personal experience than going into a large health system physician office. But that independent physician delivery system has been under enormous pressure for many years. It was accelerated during COVID. And now I think the cost pressures and the other pressures would be mentioned are really putting pressure on those independent practices. So we're doing three things to respond to that. The first is we try to negotiate with our health plans reasonable contracts that provide reasonable reimbursement or upside to those practices to help them be financially sustainable. We're also providing recruiting support to help practices bring on physicians, APPs, and so on to their practices. We help financially with the recruiting and to help balance the difference between the salary and the collections in the first year or two. And third, we're really leaning on technology. So the Epic EHR we're implementing with independent practices, and then some really powerful AI tools that help improve efficiency, more comprehensive coding for those practices to help them respond to today's consumer needs.
Thanks. I'm going to flip the script a little bit. All of you spoke, in addition to the challenges, also spoke to things that you're undertaking to help with those challenges. I'm going to push on that a little bit. I'm particularly interested in initiatives that either your own organizations or perhaps in partnership, maybe perhaps especially in partnership with others that you are undertaking. And so if you could say a little bit about what you are excited about and also where you see spots where you need additional help, whether that's policy help or resource help or whatever it is, to help those initiatives grow. David, can I come back to you on that?
Yeah, I mean, I mentioned technology, and I see the potential of the new AI tools is very exciting as a really an adjunct or a help to physicians. It's not going to replace ultimately physician decision making, but it'll support it. In some of our practices where we've implemented ambient scribe, if any of you are familiar with how that works, it's basically after you get proper consent, it listens to the physician-patient interaction, creates a remarkably detailed summary of the interaction. We see better closure of healthcare gaps, more comprehensive notes, and importantly for the physician, they're no longer having to try to type during the visit, which can negatively impact the patient experience, or or worse, trying to remember and then do it after the visit, in which case things can get lost. And we've heard anecdotally from some physicians that they're able to see 2 or 3 more patients a day, and they're done 1 hour earlier with their paperwork at the end of the day with the documentation. So that's exciting. We've also launched a pilot using clinical summarization. So if you're a patient who has a lot of healthcare issues, there might be multiple documents in your chart from different healthcare providers, and it's often not well organized, difficult to access. And so it's a perfect AI use case to take that information and deftly summarize it, but have all the drill down as well. And then thirdly, we've been piloting. Many of you on this call probably have a MyChart account, and you like to MyChart message your doctor. Well, some of those straightforward MyChart messages, like a prescription refill, could better be handled using technology than having human beings have to do the repetitive tasks. So we've also piloted that. So I think there's just 3 examples of things that can improve efficiency, I believe, and quality without sacrificing quality of care.
Thank you. And I should shout out the California Healthcare Foundation has done quite a bit of work on AI in healthcare and did a recent webinar on and presentation on that topic, and maybe we can drop that in the chat as well for people who are interested in following that thread. I'm going to go to Irene. Irene, can you tell us about work that is happening at CCHP in Contra Costa generally, and how you're working with partners there?
Yes, absolutely. One of the initiatives that we're extremely proud of is our launch of our Medicare Medi Cal Dual Special Needs Plan, also known as Contra Costa Healthcare Plus. We launched as part of a statewide mandate that all Medi Cal managed care plans launch a DSNP. And so we launched our plan on January 1, 2026. And it's been an exciting opportunity to provide more managed care for our complex and vulnerable senior population. It has been a wonderful opportunity for all of us at the plan to work with our county partners as well as our community providers. And it's been so exciting to see everyone lean in and want to be able to support our plan and also support these members. There's a very comprehensive approach that we as a health plan need to take care of these members. And we're really excited to have our community partners engaged with us as well.
Thanks. And Andy, your organizations are known as innovators in the community clinic space, and curious what you have up your various sleeves when it comes to new initiatives that help address both existing challenges and some of the stuff we see coming down the road.
Yeah, I'm gonna follow Irene and talk about the DSNP as well.
Great.
And I want to thank CHCF for helping our health centers specifically and FQHCs across the state really get a little bit more into Medicare. I've been with FQHCs almost 20 years, and Medicare has always been this just too small to talk about. The rural population often talked about it, but most health centers just did not have a patient population large enough to really focus on it. And that's, of course, changing as the population ages. And then it's also, staying in line with being community providers, it's really hard to watch your patients after you've birthed them and cared for them their entire lives, and then they leave because you have not leaned into this space. And it's a different space. Medicare is a different space than Medicaid. But want to say how excited we were. We joined an ACO in 24. That was in part due to the CHCF's education and more conversations at the state level about FQHCs and Medicare. So we joined an ACO, which enabled us to see some data for the first time, in a very different cost data, which we had never gotten to see. And we're part of an FQHC focused ACO. And the premise was FQHCs, I'm bragging, just do it better. So you're probably going to save money. And we were doing really well and weren't capturing those savings. But quite honestly, we didn't do anything in the first year. We just wanted to see what was happening. And now we have an opportunity to start really diving in on things that FQHCs have not had to do well, which is coding, just all of the more comprehensive levels of assessment. Yes, we do QI. Yes, we do patient-centered medical home. Yes, we try to do integrated behavioral health, but we tend to be stymied by a lot of law and Medicaid payment and just general regulation, and Medicare flips that script a little bit. So we are leaning into it. It's still a pretty small patient population, but the revenue opportunity is excellent. And when we are being crunched by revenue, we need to find and talk about money and figure out how we create enough revenue generation in one space that we can possibly subsidize the care that we have to provide elsewhere that is not being provided sufficient revenue. And the other thing about Medicare that's exciting for us is this is a little bit too crass of a way to describe it, but it's almost like going from third grade to graduate school, where you're like, okay, really, and it's all the things that we love to do. It's integration, and it's using technology, and it's a wider care team, and that's beautiful. And you get to have better results for your patients who are really complicated, and we want to be there. But it forces you to look at the gaps that you've had for a while, and not gaps because you did anything wrong, but gaps because the incentive structure is not in place to get there. But in the DSNP, Medicare is a mean grader. And as I've heard, they don't give you any years of permission, basically, to do anything wrong. So you have to have been there many years in advance in order to get the grade. So we are running as quickly as possible to be really good at that, because we're excited to expand and grow and be even better in what we already do. Thank you.
Thanks. And I should mention that a couple of the questions that have come in have been really to this point. And so I'm really pleased that both you, Andy, and Irene addressed that issue. James, one of the big themes in the report is about consolidations, and I'm wondering whether you can talk a little bit about how you're thinking about building new collaborations in Alameda County, given some of the changes that we've seen.
I would be happy to. You earlier in the segment talked about, in the initial slides, about the affiliation that we established with St. Rose Hospital. And it was done because we really believe that St. Rose was integral to the safety net. Our supervisors kind of opened the door and said, would you be open to this? And there was a study that was done, and it became readily apparent that if St. Rose went away, and I believe it was Andy who said it earlier, organizations might change, but the patients don't go away. And so we saw that those patients were going to inundate the balance of the facilities, including AHS hospitals, but the other hospitals in the area. And why would we miss the opportunity to allow people to get care close to home in a facility that we knew had good potential? And so we undertook that. And so about 18 months ago, we affiliated. And it's an affiliation. There are a lot of reasons why it's not just acquisition and an affiliation, and I could certainly in another time talk about that. But the reality is we are keeping care close to home for the folks in that community. And the beautiful part about this is that we announced recently a collaboration with Stanford. Stanford's leaning in. There are a number of work streams that we have with them. The first that has manifested is with our skilled nursing facility. And they are essentially buying out about 2/3 of the beds on the skilled nursing unit. So they will pay a day rate for those beds. They're filling the beds. They already have patients in them. And it allows us to have beds available for the community that has skilled nursing needs. And so I believe that there will be more of this sorts of affiliations in the future, not less. And so I highlight that because we leaned in kept St. Rose open, and now Stanford is leaning in and helping us provide excellent care there. And I do believe the synergies will, they'll pan out. They'll help us see a path to the future.
That's great. And, I'm hearkening back to what Irene said about the need for resilience, for flexibility, for creativity. And I really see that in these examples. So thank you for all of those. It's really exciting to hear about the work. I want to turn to some questions that our audience has been sending in, and apologies to people who wrote down the questions because I'm probably going to mix them up a little bit. But I wanted to ask first about workforce. That there's been a couple of questions about that in the Q&A. And as Caroline noted in her report, the Bay Area has a robust supply of healthcare professionals compared to California overall, but it certainly doesn't mean that we don't have workforce challenges given both shortages in certain areas and also, of course, our famously high cost of living. So I'm curious to know about some initiatives that you see out there that are helping or could help. And David, there was a particular question for you, I think, about the extent to which you see, given the retirement rate in the physician community, what can we expect from AI tools and some of the other things that you mentioned in terms of helping ease the burden and keeping people in practice?
Yeah, first of all, I'd say the retirement rate accelerated during the height of the COVID years. We saw a lot of early retirements from physician practices that were driven by the pressures created by COVID. In the last couple of years, that has slowed down, and I think we're back to more of a normal retirement rate. And actually, for the Hill Physicians Network as a whole, the average age of our doctors is actually slightly reduced since say 5 or 10 years ago. So in other words, the number of new physicians joining practices, younger physicians joining practices, is offsetting the impact of the older retirees. I would say, though, that the use of AI and also the appropriate use, properly supervised, of APPs, advanced practice providers, is a critical strategy for these organizations to be able to see more patients, as well as now since the pandemic, the use of video visits has become much more routine, and I think that's a very positive as well. For some patients, difficult to get in to see the doctor. There's already an existing relationship with the doctor. They can be a very efficient way of providing access. And in Hill Physicians, all of our physicians who are using our version of Epic, and almost all of them that are not using our version of Epic, offer video visit access. In addition, in the Hill Physicians Network, we've launched something where if your primary care physician is not available, then another primary care physician in our Hill network could provide that access. So we really try to load balance, if you like, across a large network. I also saw a note from somebody asked about behavioral health concerns with ambient scribe. I just wanted to address that. So I'd say, first of all, it's definitely the case that sometimes a patient would say, I'd rather you didn't record because it's a sensitive conversation. And sometimes the physician will say, I'm not going to use the ambient scribe because it's a sensitive conversation. It doesn't happen very often, but it's very appropriate. Just don't use that tool in certain patient situations. It's quite understandable.
Thank you. Andy, I'm curious to hear your follow-on that about workforce and how you are addressing the challenges and where you see the gaps.
I was surprised to see Caroline's numbers because that's not our reality. There's one health center in our network who has a 25% physician vacancy rate. We just have a really hard time on salaries. And unfortunately, in the FQ land, our payment structure is such that you need MDs, you need advanced practitioners. You can't use a number of other staff in the same way because they're not billable. So we're a little bit stymied, and then we're not able to pay high enough salaries. One of the things that there has yet to be a workforce initiative that I've seen that has had a great impact. I know all of our health centers really appreciate, and this is true across the state, when the health plans offer loan forgiveness or they offer bonus structures to help keep retention. That's most health centers don't have the ability to do that. So it's very, very helpful. We did a survey when I about 3 years ago to try to figure out where should we invest our time because nothing really feels like it's working. And one of the things that we found is that most health centers were spending more time recruiting and trying to then rather than retention, and that we were not focusing on the culture internally at the health center to create joy and balance and satisfaction and using your care team in appropriate ways, that we were burning everyone out and that we needed to think about more the culture internally for retention so that we didn't have to spend all this time running around and then chasing people to come back in. Better to focus internally. So that was an interesting aha that we've recently had. And then it's really, I hate that I always come back to it's about money, but with the providers, it really is about money because it's really competitive. I often hear stories from our CEOs. My longtime staff were offered 40% more. Like, how do you say no to 40% more in the Bay Area when housing is really expensive? And maybe now that you can live in the Bay Area instead of living in the Central Valley and commuting over the hills, right? So it just is it's a really challenging space that unfortunately it's the dollar bill that really helps us address it. But then to own that we have to focus on getting our house in order and making, and which is really, I just want to also identify, it's really hard when you're in a time of crisis to do that. But I would say, I'm not going to say that we're losing, but when it feels like your team is losing, like the thing that you need the most in that space is love. And it's okay. And we're all doing our best because it's okay to lose with your team as long as you love, because then you can win with your team. And then it feels so much better when you come out of it. But if you don't do that, then you create this kind of a sucking effect of people just being like, I got to go. It's not a good environment. So it's a hard thing to do, but it's important to center. It is a crisis. It doesn't mean it's an implosion. It means it's hard, and that doing hard work can be really joyful with people who are committed to the mission and who love it, and that we have to come back to that because there isn't enough money. So at the very least, we can appreciate, partner, and love each other along the way on this journey.
Love that. Let me pull a question about consolidation and might send this your way, Irene. What would you say has been the impact of consolidation on access and on cost? Um, is it increasing, reducing access? What are you really seeing on the ground?
That's a great question. It's kind of a large question to answer. As we've seen consolidation across the Bay Area, that's limiting the ability for us as a health plan to be able to negotiate contracts that can retain access and also manage quality and, at the end of the day, cost of care. As a former provider myself, and I was an independent practice, it is shrinking and the independent providers do serve a purpose. And CCHP is very proud to include independent providers in our network. But as we're seeing those numbers go down and seeing larger health systems absorb these practices, it's harder to negotiate and it's harder to be able to navigate the quality and the cost of care that we want to be able to provide. At the end of the day, it's a limited resource. We want to be able to use it intentionally and fiscally responsibly. But in order to do so, we cannot spend everything in one bucket. We need to be able to spread our resources equitably.
Thank you. Andy, I think at the beginning mentioned outreach and enrollment as a big piece of the system for everyone involved and the importance of that in keeping people who remain eligible enrolled as we head into, as these cuts to eligibility accelerate over the next period of time. And I wonder whether, James, you have anything to say about how, from where you sit, that work is going to happen. And more broadly, I think the role of traditional outreach workers, community-based organizations, et cetera, and kind of keeping this whole system moving to the extent that we can.
Yes, thank you, Catherine. I do want to just reflect on love. I was so grateful that Andy talked about the love of the work, and I think that's so very important because this is a lot about numbers and it's a lot about, financials. And sometimes we can forget that a lot of our caregivers got into this for that reason, because they love this work, they love the communities that we serve, and so holding that close. And so we do try very hard. Sometimes we don't get it right, but I just want to acknowledge that. Thank Andy for saying it, and certainly that's something that the Alameda Health System does hold close. She also mentioned, and she didn't say it by name, but she was referring to the HPAC, which is the Health Plan of Alameda County, and that we are fortunate because that did not go away. It was somewhat dormant, but it didn't go away. And so I think we have a bit of a head start because there is that ability to work via Health Pack as people start losing their coverage. I've been in meetings with Andy and others about how do we augment Health Pack? How do we make sure, well, let me start again. How do we make sure that people, to the extent they can keep their coverage, do keep their coverage? And so we're working very hard to provide information to individuals who do retain eligibility and to do the work necessary to remain insured. But for those who cannot or do not, there is HPAC because we do care for all regardless of their ability to pay, and that gap is widening. And so to the extent that we can help them remain insured, that we can get them onto HPAC and we can get augmentations to HPAC, and then just making sure that we're being good stewards of the scarce resources so that we can continue to provide care to all who come to our facilities, regardless of their ability to pay.
Great. I think we're going to switch to a final question with a little bit of time for everybody to answer it. I do want to just kind of sum up some themes that I think are so relevant and I think really cut across what all of you have said about the importance of partnerships, about the importance of people, and about the use of technology to support all of that. And so I really want to just recognize those as themes that seem to be underlying some of the initiatives that you're all working on. My last question is really very forward looking. We've been doing these reports now for 20 years, and we hope we'll continue to do them periodically for another 20 years. I'm using that as a jumping off point to ask you all, when you look at this region, at the Bay Area region, looking out 20 years, so in 2046, when I personally hope to be retired and maybe some of you as well. But what is your vision of what the healthcare system can look like in this region? What do you hope to see and what do you worry about in the very long term? Irene, do you want to start?
Sure. That's very forward thinking. I would say what I would like to see in the future is a continuance of what we had already been doing well, which is collaboration, integration of care, combining behavioral health with physical health, with social supports. I see the next few years as a challenge, but I hope that at some point we can right the ship and continue to do these things that we need to do to take care of the whole person. I always say at the end of the day, I'm not just the executive director of a health plan, but at my core, I'm a physician, and caring for the patient is, foremost the most important thing. And so I want to see us continue to deliver quality and comprehensive care in a less fragmented way than we're probably going to see in the next few years. We have to maintain accessibility, we have to maintain quality, and we have to continue to innovate and improve. And so I'm very excited by what I've heard on this call today and the questions that appeared in the chat. Everyone is thinking the right way, and we need to continue to collaborate together.
Thanks. David, I'll turn to you.
Yeah, first of all, I would say looking forward 20 years is a long time, of course, but I think the one thing we haven't mentioned today is the revolution in treatments for many diseases that maybe 20 or 30 years ago, there was no treatment for, especially in cancer, immunotherapies, but also many other parts of medicine. And I see us continuing that evolution of having more treatments for more conditions, more ability to treat conditions that maybe today or 10 years ago we couldn't treat. And that's pretty exciting. Now on the negative side, it's also very expensive. So I think we're going to be struggling with the cost challenge 20 years from now. I don't see that changing. On the other part is I saw a note in the chat about preventive care. I think that we in our system spends far too much time treating people who are sick and not enough time preventing them from getting sick in the first place. And this is comprehensive vaccination. This is colonoscopy screening, this is mammograms, and diet and exercise and those kinds of things. And I think I'm worried that as a system, we are starting to see some backsliding in vaccination rates in this state and in this region, and I'm worried that we're going to start to see an increase in infectious disease and loss of herd immunity. Just last week I heard, or 2 weeks ago I heard, San Francisco had a measles case, for example, the first one in I think nearly 10 years. So on the negative side, I'm worried about. I think as a system we have to figure out how to maximize those preventive tools that in our tool chest, and I'm worried that the current focus and the current barriers and the political issues are going to make that more difficult than it should be.
Yeah, it's a sobering case and sobering statistics too on the vaccination. Thank you for raising it. James.
Thank you, Catherine. I would offer that looking forward 20 years, I'm optimistic that we will have built a fully functional, coordinated, and culturally competent safety net system that is accessible to our most vulnerable residents, and one where access to high quality care is not determined by income, by coverage, or circumstance. I also see a future that I believe will be shaped by strong, enduring community partnerships. And we've talked a little bit about some of them that are already kind of growing right now, where we are deeply connected with local organizations, providers, as well as healthcare leaders. Because of these relationships, patients, I believe, will be able to receive the care they need closer to home. I talked about St. Rose and why we felt like that was super important in the communities where they live and work. And care will feel more seamless, more trusted, and more responsive to the realities of their daily lives. And at the same time, there will always be more work to do. Ensuring long-term sustainability, addressing health inequities, and keeping pace with the growing and changing needs of the communities that we serve is going to require ongoing commitment, innovation, and involvement.
Thank you. It's a great vision. Andy, do you want to take the last swing at this?
Yeah, I wholly embrace James's vision. And I would say one of the ways that we will get there is if we utilize this moment really well. This moment says there is less money and there's more need. So how then, one of the conversations we started having is like with the health plan, what's your role in Medicaid versus what the county's role is? Should not be in Medicaid, it should be for other things. And we need to create clearer lanes, but not silos, right? We need to integrate the system, but then also say, you're on first here, I'm on second. And I practice throwing the ball back and forth, right? So I'm certainly not saying this is an opportunity for connection, but being really smart about the money and how we do things. For example, in outreach and enrollment, if you're sending out a postcard on the same day that I'm doing a phone call, we should time that better. We don't do that conversation. We just started having those conversations now because we don't have enough money. We all have to do this work. The other thing I would say is I think to the preventive point, it's really important for the primary care providers to have more responsibility and more accountability and also reap the reward of having more risk. If they stay contained in their four walls, they do not see the impact of what happens when their patients leave or what happens on the weekend and they end up in the ER. They need to have more responsibility and move up in that risk ladder in order to have more control of what's going on in healthcare. And I think everyone benefits from that when the primary care providers in that care team are more invested in what happens outside of the four walls. And so I would hope in 20 years, FQHCs are a much more powerful entity, and you see more of what we all believe, prevention, primary care and prevention, leading to James having, maybe some empty beds. And we would say, yes, that's a good deal. And we'll figure out how to figure out that financing for you, but that's a good deal. We actually want less beds because people are healthier. So I would say, yeah, FQHCs more, primary care having more accountability and more resources in order to help the upstream versions of the system have less impact and less trauma. And that we are all at a barbecue, having a drink, saying we did it 20 years after the CHCF.
Excellent
Session we had. Thank you.
Well, it's a great way to finish up, Andy, and we all look forward to that barbecue. There's so much more to discuss. Apologies, we weren't able to get to everyone's great questions. Caroline, can you rejoin us? I want to thank all of our speakers, Caroline Davis, James Jackson, David Joyner, Irene Lowe, and Andy Martinez Patterson for sharing their insights, their deep intelligence, and their love for this work. We're really grateful. And I also want to thank the whole team at Yegian Health Insights and my colleagues at CHCF who make the regional market reports and these webinars possible. Thanks for being with us today. Have a wonderful afternoon.